Could FDA-approved Vyvgart, efgartigimod alpha FCAB for intravenous infusion, or Vyvgart Hytrulo, efgartigimod alpha and hyaluronidase QVFC for subcutaneous injection help your adult patients? Explore clinical trial data and learn how to get patients started at vyvgarthcp.com. Vyvgart is a registered trademark of argenx. Vyvgart Hytrulo is a trademark of argenx.
This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello, this is Halley Alexander from Wake Forest University School of Medicine, and today we're talking about seizure recurrence in women with idiopathic generalized epilepsy who switch from valproic acid to another medication. And I'm here with Emanuele Cerulli Irelli from Sapienza University of Rome, who recently published his group's research on this topic in the Neurology journal. This comes up so often in our practice, and it's really difficult to know the right thing to do in these women with epilepsy. So I'm really grateful for this work. Emanuele, can you start by telling us why this topic is so important and what made you want to look into it?
I think that our study is quite important because Valproate represents, as you know, the most effective anti-seizure medication in idiopathic generalized epilepsy. And millions of women are actually switching this drug due to its teratogenic profile. We knew from previous studies that the transition from Valproate to alternative drugs may expose women to an increased risk of recurrence or worsening of seizures. And despite the importance of this topic in clinical practice, we did not know at all the clinical predictors of generalized tonic-clonic seizures, worsening or recurrence after switching. And this information is really important for clinicians in identifying patients at the highest risk of recurrence. At the same time, we wanted to know which alternative drug was more effective as Valproate alternative after its switch, and we chose to focus on the two safest drugs for these patients, levetiracetam and lamotrigine. Our aim was basically to try to contrast, at least in part, with the knowledge gap we had on this topic.
I agree. It's so important. And women with epilepsy who are planning pregnancy, this comes up a lot. So can you tell us what you found?
We actually investigated the Valproate switch in 426 women. We recruited them through several epilepsy centers, mainly across Europe. We found that approximately 1/4 of women experienced generalized tonic-clonic seizure recurrence or worsening after 12 months of follow-up. And this outcome could be significantly predicted by 4 independent clinical factors. We found that as predictors, the catamenial worsening of seizures, the higher Valproate dosage at the moment of switch, a higher number of seizure types ever experienced, and a shorter duration of generalized tonic-clonic seizure remission before switching. We might say that female patients with idiopathic generalized epilepsy coming to our outpatient clinics because she needs to switch Valproate to a safer anti-seizure medication could be better counseled about the risk of recurrence based on these predictors. For instance, I want to bring an example, a practical example. A patient with a history of catamenial seizures, 3 seizure types, having a high dosage of Valproate at the moment of switch, a short duration of generalized tonic-clonic seizure remission may represent the scenario with the highest risk of relapse or worsening. And in this case, it could be particularly appropriate to plan pregnancy with significant anticipation. For example, it could be done 1 year before and more, and consider a very slow tapering of Valproate. Finally, we performed this comparative effectiveness analysis between levetiracetam and lamotrigine, and we found that levetiracetam was more effective in preventing generalized tonic-clonic seizure worsening or recurrence in this clinical context.
So you found that in women with generalized epilepsy, when they switched off of valproic acid, about 25% of them had generalized tonic-clonic seizure recurrence or worsening. And the predictors of that was having catamenial epilepsy, a higher valproic acid dosage, having increased number of seizure types and a shorter duration of generalized tonic-clonic seizure remission. And you also found that when switching to either levetiracetam or lamotrigine, levetiracetam was more effective at preventing generalized tonic-clonic seizures.
Yes, it is true. And regarding this last point, I was just to mention that we used a specific statistical method that can help in balancing the group of levetiracetam and lamotrigine. But despite this balancing, I think that this result could also be partially driven by the higher rate of patients with juvenile myoclonic epilepsy in our study, who represent the majority of syndromes in our cohort. And recent studies have highlighted the superiority of levetiracetam over lamotrigine in this specific generalized epilepsy syndrome.
I would have expected that maybe EEG results would have been an influential predictor for whether switching off of valproic acid was going to be successful or not. Was there anything that surprised you about the predictors that you looked at regarding which ones were relevant and which ones had less of an impact?
Indeed, we know from previous studies that EEG could be useful in the context of anti-seizure medication withdrawal. But in this specific study, EEG data were missing in too many patients and were not included for this reason in the statistical models. I can say, based on data in our dataset that we did not publish, that the simple occurrence of spike wave discharges did not seem to be strictly associated with generalized tonic-clonic seizure recurrence. Regarding the other predictors, I wasn't particularly surprised by any of them. Indeed, if you consider them, they all point to more difficult to treat cases. For instance, catamenial worsening of seizures, having experienced more types of seizures during history, have been linked to drug resistance in idiopathic generalized epilepsy in multiple studies, suggesting probably that similar predictors could mediate the risk of both drug resistance and generalized tonic-clonic seizure recurrence after switch. Dosage of valproate is quite a new clinical predictor, despite I think that also in this case it could be somewhat expected. Indeed, the higher the dosage of valproate you need to control generalized epilepsy, the higher the likelihood that we are in front of a more difficult to treat case.
Yeah, that's a great point. All of these predictors are indicators of a more difficult to treat and more severe epilepsy syndrome. So now that you've done this study, what is your process of switching women with generalized epilepsy off of valproic acid? Do you still get an EEG first? Do you bring them into the EMU? Do you switch them? And then if they have a seizure recurrence, do you switch them back? Can you talk us through your methods for this?
I think that there isn't one specific process because the switching is a really individualized approach requires. In some patients, indeed, we might expect a straightforward switch process, whereas in others, we might expect a more complicated course, also using the predictors we identified in the study. Regarding for example, the importance of EEG, despite we did not study it specifically, I think that a very active EEG before the switch could be useful in identifying patients more likely to relapse or worsen. Regarding the specific question of the switch back, I do not think that it is mandatory to switch back to valproate at the first seizure. Indeed, clinicians could try before, in my opinion, a polytherapy regimen with safer anti-seizure medication, even if the patient has already unsuccessfully used some of them in the past. Recently, Cohen and colleagues in a Neurology journal published a beautiful study comparing the combination of levetiracetam and lamotrigine to valproate in terms of teratogenic issues, and they found that even the combination is safer than the valproate monotherapy. This kind of combination should be tried before doing any switch back or something like that. Also, when speaking about the switch process, I think that it's very, very important to provide well-informed decisions to women and balance the information. This is a very complicated topic, and I think that this question also raises significant ethical issues. Because on the one hand, we have the need to control seizures, which affect quality of life, social life, work career of women, can determine life-threatening risks, the generalized tonic-clonic seizures. And on the other, we have the potential long-term consequences to the offspring. How should we balance these two things? I think that very informed decisions and individualized care are the cornerstones in this context.
Yeah, I agree. And it's always a balance, too, of the fact that generalized tonic-clonic seizures are dangerous to pregnancy as well as being on valproic acid. So there's a risk-benefit to decide there as well. In your opinion, do you always attempt to switch women with epilepsy who are planning pregnancy off of valproic acid? If not everyone, then how do you decide which patients to switch?
I think that is another very important point, and I don't think there is a one definite answer again. I think that the more important thing is that if you think the patient has a high risk of recurrence or worsening because she has a very difficult to treat epilepsy, and she should be informed well about the risk of worsening and recurrence, and she should be well informed about the risk of valproate. Valproate also has risks, according to recent findings from an international study groups, at low doses, because sometimes people say that if you prescribe valproate at 600 milligrams, you should have lower risk. But this study found that also at doses below 650, the risk is very high for major congenital malformation compared with levetiracetam and lamotrigine. So I want to stress again the importance of explain well to the women the risk they have from continuing it and from switching it.
Exactly. Yeah. And sometimes, like you said, it really is an individual decision. But this study that you've published gives us some information that we can share with these women to help them make the best decision for them. So thank you so much for doing this research and for joining us on the podcast today.
Thank you very much for the invitation.
Be sure to check out the full article, which is published in the May 14th print issue of Neurology, and that's titled Predictors of Seizure Recurrence in Women with Idiopathic Generalized Epilepsy Who Switch from Valproate to Another Medication.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.